So welcome everybody. Good morning, good afternoon, and good evening. My name is Marianne Atiabet, and I am the lead of MSD for Mothers, which is our company's $650 million global health initiative to help create a world where no woman has to die giving life. I am so excited to invite everybody here, or actually welcome everybody here, to the Lives in the Balance Summit series, where today we're going to be talking about delivering on our commitments to improve health equity through multi-stakeholder collaboration. This is part of a series. It's the fourth part of a series, following up from yesterday's fantastic event. So we have lots of amazing speakers lined up for you today that bring not only their expertise and their experience, but kind of real life, real from the front lines perspectives and insights on being change makers and really creating the world that we want to see, where no woman has to die while giving life. I know you want to hear from them, so I will, without much further ado, get to it and start with inviting David Clarke, who is the acting unit head of health systems, governance, and policy at the World Health Organization, to also welcome you all and with some opening remarks. David, over to you.
Thanks so much, Marianne. Welcome everybody to the webinar today. It's a really important topic. This topic is something that's been growing as a topic for quite a long time. The topic of the private sector in health is an old topic, but when it comes to universal health coverage, I think the UHC agenda really reinvigorated the importance of making sure that if we're going to achieve universal health coverage, and particularly health for all, and leave no groups behind, that we really do need to work productively with the private sector. So this is a very important agenda for WHO and for everybody on the call today. We've been working on this agenda since 2018, when the late Pete Salama, through his leadership, asked us to start to work systematically on the private sector and universal health coverage. And over the last 2 years, I think it's really clear from the work of the colleagues on the panel today and from WHO's own work, how important it is to better engage with the private sector to achieve better health outcomes for all. And particularly in the last 2 years in relation to the health outcomes for women and children and adolescents. We all acknowledge that over the last 2 years, because of the COVID-19 situation, we've seen problems with countries maintaining essential health services, particularly for these groups. So we've really had to double down on our efforts to work more productively with the private sector. So with no further ado, I'd like to just turn it back over to you so we can hear from the panelists. But with just one last thing I would like to highlight and invite people to contribute to is that with support from some of the colleagues on this panel, we also have a very important initiative that some of you may have heard of called the Country Connector on the Private Sector in Health. In that initiative, there is definitely a focus on maternal and child health, and we'd certainly like to see all of you participating in that initiative as it goes forwards. But back over to Marianne for the panel. Thank you very much for this opportunity.
Thank you so much, David. As all of you have heard, the importance and the significance of the private sector can't be underestimated. I think many of us have experienced that, have seen it, have felt it during the COVID pandemic. I'd also like to ask Caroline Quijada, who is the Executive Committee Representative and Chair of the Private Sector Constituency at PMNCH. She's also the Deputy Director of APPS Sustaining Health Outcomes through the Private Sector Plus program, to talk about some of the work PMNCH has done during the COVID pandemic to ensure that we're still meeting the essential services that women and children need, and what the role of the private sector has been through that cause. Caroline?
Thank you, Marianne, and everyone else joining us today. We welcome you to our session. Yesterday, during the fourth edition of Lives in the Balance, we saw and heard political leaders, decision makers, and community voices standing up to shine a light on the need to address inequities in humanitarian and fragile settings. The conversation addressed the urgent need to mobilize and deliver on commitments for women, children, and adolescents who have been severely affected by the pandemic and continue to experience conflicts, coup, and other social and economic fallouts. Yesterday's event was part of a series launched in 2020 by PMNCH and Core Group that has served as a platform for partner-led dialogue and the PMNCH Call to Action on COVID-19 campaign. This call to action aims to prevent the COVID-19 pandemic from becoming a lasting crisis while forging stronger primary healthcare systems as a pathway to achieving universal health coverage and fostering a more equitable world. To date, $32 billion of commitments from countries and donor organizations have been announced to restore essential health, nutrition, and social services for women, children, and adolescents lost because of the COVID-19 pandemic. At the same time, we have also seen a shift in what we are talking about and by whom. Citizen action, multi-stakeholder participation, including from the private sector, and greater accountability is at the center of our work together. Today, as 10 PMNCH constituencies, we are uniting 1,200 organizations, the world's biggest alliance for women, children, and adolescents. We are powerful in what we say when we speak together. It is my pleasure as the chair of the PMNCH Private Sector Constituency to welcome all of you to this special event, Lives in the Balance Summit Series, delivering on commitments to improve health equity through multi-stakeholder collaboration. Today, we will focus on contributing to PMNCH's efforts and engaging the private sector in multi-stakeholder efforts, who play a critical role in achieving the SDGs and in advancing universal health coverage. We are glad you are here as we embark in this conversation on how private sector can contribute to the delivery of commitments for women, children, and adolescents. I apologize for my dog.
No, Caroline, he wants to join. He wants to join. And he likes what you're saying.
Yes. Despite remarkable gains in maternal and infant mortality rates, we are still falling short of the Sustainable Development Goal 3, which looks at reducing global maternal mortality to less than 70 per 100,000 live births and neonatal and under 5 mortality to at least as low as 12 and 25 per 1,000 live births, respectively. One of the biggest barriers to achieving these goals is sustainable financing. The private sector has the potential to play a role in closing this gap, from reducing out-of-pocket costs for private services to making medicines more affordable and leveraging new tools. There is an annual $33 billion financing gap affecting reproductive, maternal, newborn, child, and adolescent health. Private sector engagement, as David stated, is needed to address this gap and advance efforts towards achieving these goals. What does this engagement look like? It looks like private sector is a partner in creating financial instruments. Private sector capital can close the $33 billion financing gap. What else can we do to engage the private sector? There's business, technical, and scientific expertise that can be leveraged to close the innovation gap. And more importantly, we can support and include the private sector as a partner in service delivery. In addition to this gap funding, yesterday we learned that more than 2 billion people, including half of the world's poorest populations, are currently living in humanitarian and fragile settings. PMNCH's board chair, Helen Clarke, highlighted how a record high number of people, mostly women, children, and adolescents, are in need of assistance due to crises and conflicts, climate change impacts, and disasters. Approximately 1/5 of the world's population of women and children are living in countries experiencing armed conflict, and nearly half of global under 5 deaths in 2020 occurred in fragile and conflict-affected situations. These and other shocking realities must make us question what our role is and what each of us can do to address these inequities. There's no time to lose. The PMNCH private sector constituency and other partners are ready to take action and speak out with one voice for a more equitable world where no woman, child, or adolescent is left behind. So again, what role can the private sector play in helping countries meet commitments in response to the PMNCH call to action on COVID-19? They can serve as a partner in delivery of essential services, including for marginalized populations. In many fragile settings, it's the private sector that fills the gap when public services are disrupted. The private sector can also join forces with civil society groups and advocates to serve as an influential force in advocating to governments to make good on their commitments. And the private sector brings many innovations that can help lead to efficiencies and stronger responses. Finally, I just want to say that private sector is friend, not foe, and they deliver services along the socioeconomic spectrum and are an important partner in helping us to achieve UHC throughout the world. Thank you for your time, and I look forward to continuing this discussion. Thanks, Marianne.
Thank you so much, Caroline, and thank you to your dog or your puppy, who brought a certain sense of levity, to the proceedings. But I also want to thank you and the leadership of PMNCH, for all the work that you have done during this pandemic. The COVID-19 call to action, as you mentioned, has now achieved pledges of over $30 billion in commitments for better financing for policy and service delivery for women, children, and adolescents' health. And that's essential because we know that the gains that we made, pre-COVID have been clawed back. We knew that we had to accelerate and double our efforts at least twice as much before COVID. Now it's looking, we're going to need to run 4 to 5 to 6 times faster, and in fragile states, even more. And so how do we make sure that we can maximize, we can optimize, as you mentioned, all of the important contributions from the private sector? We also want to make sure that we are all learning, as we go along, and making sure that those learnings and insights, are able to inform future efforts, because as we've all understood, there's no time to waste. So you talked about the many different ways private sector can contribute. The case study that we have prepared for our audience today speaks to one of those important ways, the contribution in service delivery by the many local private providers that exist across geographies, as you mentioned, often in fragile settings, rural areas where there may not be accessible public sector facilities, and often are the vanguard, of service delivery in fragile settings. However, and this is something MSD for Mothers, really has thought about in terms of how do we help to harness, those contributions of the private sector in a way that's going to result in improved lives for women, girls, and children and adolescents. And we know that despite, as you mentioned, many countries having mixed health systems, oftentimes we see that the private sector is a very large and diverse sector. And often people are not sure or aware, of the quality of care that they may get from the diverse different types of providers in the private sector. And so one of the things we thought about is how can we work to make sure that not only quality is, quality is of high level, but there is broad awareness, of the safe, high quality and respectful care that's being delivered in the private sector. And thus, be able to supercharge, the ability of local private providers to augment government health systems capacity. In India, for example, of which the case study that you all be able to hear from is based, we've seen maternal mortality rates improve significantly. But India still has one of the highest burdens of maternal mortality in the world. It's an MSD for mothers focused country specifically, for that reason. And one of the things that we recognized when we started to work and collaborate with partners in India is that up to 50% of women are seeking maternity care from the local private sector. But that there was no consensus on national quality standards for private maternity care and no national accreditation to assure the quality of this care. I'm happy to say, 10 years later, that those statements are no longer true. We have the Federation of Obstetric and Gynecology Societies of India, FOGSI, that leads Manyata, a national quality certification for private maternity care providers that's based on a quality improvement model that significantly improves private providers' adherence to WHO-aligned quality standards. And through this Manyata certification and facility-based training and mentoring, FOGSI is working to assure the quality of care in public and private facilities in 21 states across India. And to date, over 1,200 providers have achieved Manyata certification upon meeting quality standards. And FOGSI has been doing this, in collaboration and partnership with government and different government agencies of which you will hear from today. You'll also hear from Ariadne Labs, which has conducted a comprehensive review of Manyata. Because as I mentioned, I do think, and we all think, that it's very important to share learnings and experiences, as we think about how we can scale up, this model of pulling in local private providers and private sector contributions in service of maternal mortality goals. So I'd like to start by inviting Megan Marks Delaney, who's a research scientist at the Better Birth Program at Ariadne Labs, to share with us some of the findings that her and her team would like to share with you in terms of understanding the extent that Manyata is able to address existing gaps. So Megan, over to you. Can you provide some preliminary insights outlining how and to what extent Manyata is responding to the essential health needs that we've heard about?
Thank you so much, Marianne, and thank you for the opportunity to share these results with you today and for the fellow presenters who will be talking on the importance of the private sector. Can you see my slides? Okay. I'm speaking on behalf of my many colleagues who've been involved in this work, including my team at Ariadne Labs, the JPIGO team in India, and colleagues at FOGSI, who are also on this call, who have all collaborated closely in analyzing and interpreting these findings. So thank you. I'm fortunate to work at Ariadne Labs, a joint center between the Brigham and Women's Hospital and Harvard Chan School of Public Health, where we believe that the greatest opportunity to improve health and well-being for people everywhere is in the science of health system innovation. And our ability to capture and analyze data to improve childbirth care led us to this collaboration as a learning partner for Manyata. Around the world, the quality of care remains a major barrier in combating childbirth-related mortality. This is what we've been talking about. The private sector is not immune to poor quality, with challenges in both undertreatment of some ailments and overtreatment in others, specifically often in childbirth around the use of cesarean delivery. An additional challenge within the private sector is the paucity of data, with often scant oversight to understand and remedy some of the current gaps. The WHO Safe Childbirth Checklist is a starting point for improving quality around the world. And indeed, it provided the basis for the quality standards that are used in Manyata. The Manyata program, as Marianne mentioned, is a quality improvement and quality assurance program that is affiliated with a professional society, FOGSI. To guide our learning on Manyata, we looked into three major areas: to understand why facilities opted to join Manyata, to understand how facilities succeeded or not in improving quality and adherence to standards, and understanding what's needed to sustain quality. For this analysis, we conducted over 200 qualitative interviews with stakeholders from doctors and nurses to implementers and assessors and leaders, and additionally used programmatic data for additional quantitative analysis, including observed adherence to standards and facility self-reported data. Understanding why private facilities did or didn't join Manyata is important programmatically to understand how to target recruitment, but it also helps the larger public health community to understand private facilities owners and doctors' motivation to participate in this type of program and what needs they have. Facilities that joined Manyata were generally small, with fewer than 30 births per month and had an average of 1 to 2 doctors. Among the 410 facilities included in our analysis, a little over half received an in-person quality improvement and assurance program, while the rest received a digital program. Qualitatively, we found that the primary motivation for joining a program like Manyata to improve quality really included access to staff training, to allow nurses to receive refreshers and to get that training in practical skills. Additionally, many participants valued the introduction of new protocols to guide care and for instituting systems within even small facilities to make the care more efficient and to standardize care across all of the patients. FOGSI was also seen as an important the affiliation with FOGSI was also seen as a really important aspect of what motivated facilities to join into a quality program and become a part of this. On the other hand, the accreditation certificate itself and the ability to increase fees were not reported to be major motivators, but really it came down to support for quality was what was missing in some of these facilities. In terms of success, we found that at baseline, the quality in these facilities was quite low, but there was great improvement seen across all of the 16 standards, which I think is a real success, all of the substandards as well. And that was noted across all of the geographies that were measured, and mentoring that was both in-person and digital. So it was a pretty robust program that could be, that had a lot of flexibility. You can see from each of these small multiples that it represents the percentage of facilities that were able to achieve a given quality standard at each of the time points. Early wins included supply preparation. We've seen that before across many studies. And challenges that remained included management of complications and those initial steps to take once you recognize a complication to start to act on that. Some of the challenges, it's important to remember that one-size-fits-all solutions don't generally work. And so it was important to know that there's not just the private sector, as you mentioned. The facilities are quite varied. And so the approaches and the flexibility in approach were really important in terms of the success for Manyata. Sustainability strategies for quality are obviously important. And in this program, there was a strong call, again, on that training theme to have access to ongoing training to support new staff that are coming on and to address staff turnover so that everyone can take part in Manyata. As we think about the role of the private sector in achieving universal healthcare, Manyata provides a good example of how to engage with the private sector to encourage them to join and to buy in, how to support private facilities in their quality journey, and the ongoing training and oversight that's needed to sustain quality. It's important to continue to find ways to support and ensure that private sector facilities deliver excellent care for every woman and every newborn everywhere. Again, thank you so much for the invitation to present and share these findings today, and I look forward to further discussion. Over to you, Marianne.
Thank you so much, Megan. And for the audience, I know that her slides and her presentation have given lots of fodder. So please think about your questions. You can start to put them in the chat because we are saving time for a Q&A session. I'd like to now move to Dr. Jaideep Malhotra, who is the former president of FOGSI, which, as we all know, is the Federation of Obstetric and Gynecological Societies of India. She's also a gynecologist, an IVF specialist, and founder of one of the first Manyata certified facilities, the Rainbow Hospital in Agra, which I've also, had the pleasure, to visit. Dr. Malhotra, as one of the many leaders of FOGSI, you have been instrumental in the success of Manyata. I would say the FOGSI champions are the key secret ingredient, to its success. And I don't know how we will be able to replicate that championship that you bring to this program. Would love for you to talk a little bit more about how the private sector has contributed to India's public health and maternal health goals, specifically how you may have seen the role shift over time or evolved over time, especially during the last couple of years in the context of the COVID-19 pandemic.
Yeah, thank you, Marianne. It's a very unique opportunity for me today to be presenting, some of my thoughts. Because if you know that I'm the third generation obstetrician and gynecologist in a private sector hospital, and the family has served for more than 70 years with 2 hospitals, one definitely totally dedicated to maternity care. So we've actually really seen, and for my 40 years of practice, I've seen a great shift which has happened over the years in many things, which are maybe some are good, some are not as good, and some definitely need our attention. Now, first of all, we need to understand that there are countries who have all different health systems. Now, these systems, there are many countries which have only public, there are many which have, public and private, and it's very, very important for us to understand these systems, because ultimately any system which we may have, the efforts are only directed towards one thing, that each and every woman deserves and should get the kind of care you and I get. And that's very important, because wherever any woman may go during her pregnancy, she should be having a healthy pregnancy and a safe childbirth. Now, we need to create something like that, an atmosphere where women feel really confident. Now, when we come to private sector, now many countries, I'm talking especially of the developing, the low and the middle income countries. Now, what we did really understand is that there is a significant role of the private health care providers. Now, especially in the healthcare across the world, it's not only in our region, but it's across the world and across all income levels. Now, if I just talk specifically of the low and the middle income countries, almost about 40% of the family planning or the contraceptive services, antenatal care, institutional deliveries are provided by the private sector. And if I talk specifically about India, over let's say about 2 decades back, I used to proudly say 70% of the women in India used to seek maternity care services in the private sector. We have seen a shift today. Still, almost about half of the institutional deliveries are actually happening in the private sector. So the role of private sector cannot be undermined, and that is something which is very, very important for all governments to understand and engage with. And as a president of FOGSI, I made enough efforts, and before and afterwards also, we are just doing that, because unless and until the private sector is fully engaged, this access is not going to be achieved. Now, there are challenges in this, and I would say the same challenges are there in public sector as well. Now, the standards of maternal care, sometimes, in they do not exist, or they're really inconsistent. And this is again across the health systems. Now, how do we really standardize? How do we define standards if there is no consensus? Now, what is a measure? And we do have some measures, but reporting on the quality. What is the quality like? What are the standards of quality care? Whether it's public or private sector is something which we need to define. And in India, as many other countries, I would say that this consensus on the national quality standards for private maternity care and even the national accreditation on the quality care is still, a bit challenged. And I think we need to really work on this. Now, as you rightly said, that I happen to be the 57th president of FOXI, which is the Federation of Obstetrics and Gynecological Societies of India. Just for people to understand, it's one of the biggest organization of OBGYNs in the world, because there's only OBGYNs. And we have a representation in 262 societies, along with 40,000 OBGYNs who are the members of this federation. Now, what is important is that in 2013, after delving a lot, because most of our members are in the private sector, and there were challenges which we were feeling that we need to really work on, because we had realized that the government was definitely trying and putting all its efforts in the public sector, and the private sector needed some support and hand-holding. So I would really like to place on record my sincere thanks to MST for Mothers for partnering with FOXI in 2013 and responding to this challenge, because it was a very, very important thing. All of us who were working towards in the globe, our MMR and neonatal mortality used to really put our heads down. And FOXI developed a beautiful program called Manyata, and we implemented it. And it's like a quality certification for the private sector, because the private sector providers needed that QI model, and they needed some hand holding and some quality assurance and adherence to the WHO programs on quality standards. And the impact of the program was so much that initially we were very slow, because I would say that till about 2 years back, we were only represented in 3 states. And from there, the trajectory of growth has really, moved so fast that today we are in 21 states. And that's a huge, huge leap, because people in the private sector have started realizing that, yes, this is the way forward, and this is something which is definitely required. And I can boast of 2,000 facilities today in the private sector, which have been actually assessed and certified by FOXI for these quality standards. And what is more important is that during this course, we realized that we need to establish the centers of skill enhancement. And we established 8 centers of skill enhancement, and to manage the QI program with providing, technical assistance in training and skill development to the facilities. And the best part is that this pandemic has taught us so much. Initially, all these things were being provided, in person. The team used to travel to the hospital, and pandemic taught us a lot about digital platforms and, educating the public and the people online, which has really eased out and has become very, very cost effective. So this has been a phenomenal program, and thanks to MSC again.
Thank you so much, Dr. Malhotra. That's so amazing to hear, and would love to pull in Dr. Maidan Gopal, who I know has been a staunch partner and collaborator in this effort. Dr. Gopal is a senior consultant at NITI Aayog in the government of India. So welcome, Dr. Gopal.
Okay, thank you, Mary. It has been being a witness to the journey of Manyata, because before joining NITI Aayog, I was I was assisting the Manyata program. We should understand that the quality plays an important role. I will just give you some data points. The recent National Family Health Survey data, which points that the institutional deliveries have improved, because to reduce the maternal mortality rates, so no woman should die, the government is having an inclusive program. As a result, the institutional deliveries have gone up. But side by side, the breastfeeding during the first hour, that has dropped. That means something is missing. What that is missing? Adherence to the protocols. Had there been some protocols, as we have been talking, then this indicator should also have moved in the positive direction. Okay? So it's a contrary to this kind of. With this observation, I will start saying this Manyata means recognizing. Recognizing, it's a Hindi term, or it can be used in Sanskrit also, Hindi term. That means I recognize you, your efforts, your processes. This is very much required. As we know that India is a mixed country where we have a fragmented health system. Public sector is there, organized sector is there, private sector is there. The footfall in the public and the private, they are the same. That means the utilization of the services, the private and the public is same. But the expenditure happens more on the private side. 70% of the expenditure happens on the private side. And most of this expenditure is out-of-pocket expenses. That means 1.4 billion people chasing after around 1.1 million providers for the healthcare. They are negotiating for the healthcare. So a lot of efforts were happening around the quality sphere, means how to ensure quality to these providers. We are having so many providers, how to ensure the quality. As my previous speaker, they have rightly pointed out that the government sector, they are focusing on improving the maternal care. They do have quality standard. They have adopted the WHO checklist. They are having their own program. But what to talk about, as rightly pointed out, 50% of the women, they seek antenatal care in the private sector. So where are the standards for that? Do our women, they need to be treated? Because if you look at the private sector before the advent of Manyata program, you see the condition. They long for these private providers, they long for quality, but they don't know what to go. The NABH, the other quality accreditation, they are expensive and they are time consuming, a lot of process driven, and it's more or less centered around the patient safety. They don't talk about the outcomes and the output, which this Manyata program talks. They talk about the outcomes, how the outcomes of the maternal care, how the outcomes of the mothers, have they improved or not? It talks about that. That means from the routine accreditation process, it has taken to a next step. That means it has gone for the outcome-based standards. It has gone in that direction. Having said this, we have been partnering with them. They have trying to see that, because at Niti Aayog, we are having an aspirational district program. That means if you want to, as a leader for SDG goals, if you want to achieve the SDG goals, we have to focus on few of the districts. And these districts previously were known as high priority district or the backward district, but we call them aspirational district because these are the districts which aspire to be sitting with the normal districts. In this also, we have been in discussion with the Manyata program, seeing that how they can come into this aspirational district and help the private sector in this aspirational district. For the government sector or the public sector, we are having the Lakshya program. For the private sector, we are in discussion, consultation with them, how to engage and how to roll out this program for the private sector people in this aspirational district. It's a huge footprint, and we all talk about scale. The moment these are fruitful, you see the scale would be there, and see that how this scale is implemented the moment this partnership happens. That's one thing. Another thing is we have to see as a periodic evaluation. Around 1,000 plus institutions is a small number. The number needs to make a leapfrog. We should be focusing more and more of the private providers, because that number is small. In the PMJ program, which is basically talks about the secondary and the tertiary care, we have having around 25,000 healthcare providers. and half of the numbers are from the private sector. If you take the number, that means around 15,000 private providers in that program. 1,000 number is too small a number. We need to quickly take a leapfrog and upscale this thing. We are expecting that kind of thing from this Maternity program. I will stop here. If there are any questions, willing to take that. Thank you very much for this opportunity.
No, thank you so much, Dr. Gopal. And I think your comments speak to two things. One, the importance of equity. You mentioned the aspirational districts and the collaborations that are happening between public and private sector in those aspirational districts to make sure that we are focusing our efforts where they are needed the most and where we know that socioeconomic conditions, are causing less access, to high quality care. We've heard from the private sector with Dr. Malhotra. We've heard from academia with Megan. We've heard from the international NGO sector with Caroline, and we've heard from government with Dr. Gopal. But the most important people that we need to hear from are actually the voices of women and girls who are having lived experiences and making sure that the experiences and the recommendations and the knowledge and the insights that they have about what's best, for the pregnancy and postpartum care continuum, as well as the full gamut of reproductive health services is most important. So it brings me great pleasure to be able to invite Sandra Moriana, who is an advocacy and program manager at the White Ribbon Alliance in Kenya, to speak to us about not only about the work that she does and her colleagues do, but why that's so important. Over to you, Sandra.
Thank you, Marianne, and greetings, everyone. It's an honor to join this session and to be having this very important conversation. To address what we do, I'd like to spotlight the journey to collecting women's and girls' voices, because that is what is key to this conversation. Poor quality of care has been notoriously attributed to poor maternal and newborn health outcomes. And in fact, starting in December 2016, White Ribbon Alliance volunteers and supporters in communities across India asked women what they really wanted from a health facility for the best quality of care for reproductive and maternal health services. So using this tool, the Hamara Swasthya and Hamara Hawas card, they were able to collate, and categorize the most pressing needs around quality of care for these Indian women that they had asked regarding their childbirth experiences. And this then inspired a movement-wide listening exercise, because we saw how important that was. So in 2018, curious to know what quality of care means to mothers, we asked over 1.2 million women and girls globally to tell us the one request for quality maternal health services. Dear distinguished guests and colleagues, the results were far beyond what maternal health experts and existing health norms and standards, as we've been talking about, define as quality of care. Respectful and dignified care was number one, followed by water, sanitation and hygiene, medicines and supplies, increased competent and better supported midwives and nurses, and close and functional health facilities emerged as the top high-ranking asks. And so 3 years on, White Ribbon Alliance has continued to listen, to prioritize, and to elevate the voices of women and girls through targeted country advocacy actions. She needs to set the agenda for maternal and newborn health policies, programming, and practice. The persistent gaps that we see in health equity will indeed be closed when we intentionally listen and are informed by the diverse and unique lived realities of women, girls, and mothers. And I'd like to spotlight Kenya, because that is where I am based and most familiar with, and really directly engaging with the communities here. So we have closely worked and supported women and girls living with disabilities at the subnational level to redefine the health priorities. Armed with the What Women Want asks, they have used this to develop robust community action plans that have then given them confidence to boldly express their health rights and safely negotiate their health demands. Health equity is central to achieving UHC, universal health coverage, which means concerted efforts must be devoted to targeting those who are hardest to reach and have been previously left out, like this subpopulation. To improve health system responsiveness to the needs of women and girls with disabilities we have seen, governments should leverage partnerships with the private sector actors and other stakeholders to invest in competencies in health service delivery, especially for reproductive and maternal health services, to ensure it promotes dignity and is non-discriminatory. As we saw, that is a one key ask by women and girls. But then also resources should also be directed to training health workers in disability awareness and facilitating health facility layouts and equipment that are disability friendly. There's a big opportunity there for private sector engagement, as we have seen in our context. Indeed, it is through this multi-sectoral and multi-stakeholder action that women and girls living with disabilities in Kenya, particularly in Bungoma and Makueni counties, have successfully demanded for changes in quality and inclusive healthcare locally, whilst also ensuring that their perspectives have informed national action and processes on universal health coverage. Specifically, health facility decision makers in Bungoma and Makueni counties listened to them and acted by installing disability-friendly infrastructure in target facilities to include ramps and inclusive toilets. We saw revamping of maternity wards to become more inclusive. That has been a big gap in health equity, and improving facility cleanliness and sanitation. WASH was a very key ask by the women and girls. And this has positively impacted the health seeking experiences of over 14,000 persons living with disabilities in both counties. So we insist and we say that if we are truly going to have this conversation genuinely and meaningfully, then if we're talking about standards, we must bring in the voices of the women and girls, because we have directly seen the impact it has had on their lived experiences, some of them unique, that can get lost in the bigger framings and macro agendas. I will leave it there and maybe give more submissions in the question and answer and maybe the call to action. Thank you.
Thank you so much, Sandra. Your words are so important. And one of the things I think that we've learned through this journey is that the systems and processes are not in place to routinely, not just seek out, but for the voices and recommendations of women and girls to be an integral part of how we design systems and how we hold them accountable. And so it's been a great honor for MSD for Mothers, to work with White Ribbon Alliance to build some of that capacity, that will help really routinize, that integration of voices. And that actually leads me to one of the questions we've already got in the chat. So we're now moving into the Q&A session, where somebody asked about the specific role of private sector as it relates to introducing technology and new innovations, to help us meet our goals. So I'd actually love to speak to you first, about the role of technology in helping meet the goals.
Yeah, no, that's a very good question. And that's how we've even seen a very positive collaboration with the private sector through your partnership with MSD. We have been able to see the success of collecting voices, because we as I've emphasized, listening exercise and truly listening to women and girls is foundational to advocacy that works, to actually getting the outcomes that we are seeking for. And so what we have done, we have gone to digitize that listening exercise so that we can not only continue collecting these voices and the priorities, but also reaching populations that we could not reach before. When we had this listening exercise in Kenya, and actually really broadly, at first it was really a paper survey. So we really had to mobilize on the ground to go and listen to women and girls. And so we thought, how else can we improve that process. And so that is how we were able to partner with, MSD, with the private sector to develop this tool. And this tool will not only reach populations that we've not been able to reach, but then we've also integrated innovations within the tool that will able to even improve that feedback. So we're not just collecting voices, but how do we collect those priorities and directly inform policymakers and decision makers? And so there are tools within that innovation that speaks to that.
Yeah. No, thank you so much. And I think I love what you said. Digital innovations are actually helping you reach people you couldn't reach before. And I think that's something that sometimes we don't always realize, or we don't always think intentionally about how we can use innovations to get to the last mile. I'd love to invite both Dr. Malhotra and Dr. Gopal to also speak to this issue. I know how difficult it can be to introduce new tools, whether it's technology or digital platforms into the exam room, with the patient, and even how difficult it is to scale up introductions of technologies into facilities, hospitals, and health systems. So first, Dr. Malhotra.
Yeah, Marianne, I think this was probably one of the biggest challenges. I'll give you one small example from my own hospital, because I always, used to hear this word that India is a DRIP country. It is a data rich and information poor, data rich and information poor country. And we never had any kind of documentation. And I always saw a reluctance of people to document things because their understanding about certain the thoughts about certain documentation was absolutely different, that if they document, then they're going to be held responsible for the mistakes or whatever. Now, when the pandemic came, the major problem was now how to reach out and, do certain things, how to have access to the patients, to the healthcare providers, and to the management staff in the hospital. And I think India has actually done very well as far as, technology is concerned. The only problem or the challenge which we faced, like if there was a software available, in spite of all the training programs, the reluctance was there. But today, we are slowly overcoming. And I again would like to thank MSD for this Manyata program. At least in my hospital, if a third person comes and tells the importance, I have been educating my staff for all these years, 40 years, please use, and please document. But when a third person comes and tells and educates them the importance, I think it was received much better than they received from me. And I mean, that's really, really an important aspect. Then reaching out to patients, like there were so many apps, like even with Manyata, we have an app where we are educating the nurses on how to deliver safe. And it has really uplifted the whole system. And I think it's a huge, huge plus for a country like India, which is huge, 30 million births happening. And we have only 100,000 OBGYNs to do the job. So we need to really train people around and use all the tools available to be accessible, affordable, and cost-effective, and produce the outcomes which are required.
Thank you so much, Dr. Malhotra. Dr. Gopal, private sector partnerships around technology and innovation?
If you look at the way things have progressed during the last 2 years, during the COVID times, when NITI, along with the Medical Council of India, we have released a telemedicine guidelines, making teleconsultations and other things legal in the country. Before that, the honorable courts, they have taken cognizance of that and they have passed orders. So there was quite reluctance among the people to provide teleconsultation, other things. Another thing which has happened is our telemedicine platform is now evolving. That means if you look at after the release of these guidelines, the public sector, they are having an e-Sanjeevani, and you are having a similar kind of platforms in the private sector. Many of the e-pharmacies, they are providing teleconsultation services. In that way, that consultation services, the barrier of access is more or less trying to address that. Before that, there were some efforts from the public sector side in the form of the telehealth services to the government system. these activities are going on. But if you look at how the technology is leveraged for building capacities, you look at the Manyata program, and the NAPH program, accreditation program, now everything is coming online. That means you have to assess yourself based on the inputs which you are giving to a technology platform, and that will throw you questions that way, have you done this, have you done this? Then the moment you adhere to that, now you get an answer that in which direction you have to go. So apart from providing access to the beneficiaries, now you are trying to capacitate the providers also in building the quality aspects. It's not only just for easing the day-to-day transactions, as Maluta madam has told, but we have to see that how we make an access so that he understands the importance of quality by using a small tools. Now we have going into the accreditation, certification, recognizing and building qualities as well as capacities through use of technology. So now things are becoming very easy. Now this is an example. You see, had it been a physical meeting, it would have been very difficult to manage logistics and other things. Now across the world, one is sitting in the different time sphere, and we are sitting in a different time sphere, and we are all interacting. And this has been very easy for us.
Yeah, no, thank you so much. And, you know, the point you made about technology allowing you to get to places where perhaps folks were not able to access high quality care, you know, is an apt one, and links to a number of questions we're seeing in the chat around how to ensure equity when we are pulling in private sector and local private providers, you know, into this work. And I'd love to ask Caroline, you know, and perhaps David to speak to that. Caroline?
Thanks, Marianne. I think it's an excellent question, and one that we often hear when we discuss private sector delivery of care. I think there's many mechanisms. I actually think digital technologies is one way to keep costs down low. There's lots of models that use telemedicine or digital technologies to help reduce the cost of delivering care. Both Drs. Malhotra and Dr. Gopal mentioned the issue of scale. I think digital deliveries also helps you achieve that scale that's needed. There are financing tools that can also help increase equitable access to private sector care, particularly in those communities that have no access to care. Things like contracting with government, voucher programs, many social enterprises that go down market, delivering, you know, really low cost, high quality care based on volumes of services. And I think India is a great example of where that's really been optimized and leveraged to increase access across the socioeconomic scale. But I do think that, you know, what it really takes is looking at the system as a whole, understanding where private sector can fill a gap, where they can do things perhaps a bit more efficiently than the public sector, and places where it doesn't make sense to have private sector delivery that's delivered on behalf of the government, right? So I think what it does take is dialogue, communication, data, understanding, you know, what services is the private sector delivery, and then just more importantly, partnership. I don't know, David, if you would agree with my response.
Thanks, Caroline. So this really goes to the heart of the work that we do at WHO, because our view is that our member states are health system stewards. It's their responsibility to make sure that everybody has access to equitable health services that are of sufficient quality and for financial protection. So really, for us, it's a big role for government. I mean, obviously the private sector will play, there are many private providers who will play a very important role in relation to making sure that we improve access and quality of health services. But unfortunately, there are some who don't. And we need to make sure that the policy frameworks, that the regulatory frameworks and the partnerships that are put in place, led by government, actually are designed to achieve the goals that the public health goals, that is equitable health services, quality health services, and financial protection. And I'd just like to add one last thing. And I think that just reiterating what Sandra was saying, I think the North Star in all of this is the health consumer. I mean, this is what today, this is what we're talking about. This isn't an abstract discussion. This is about the services provided to health consumers. And so therefore, I think it's important that we think about that in any of the work that we do in this area. Thanks. Bye-bye.
No, thank you so much, David and Caroline. And I'd actually love to add something, to this discussion around how do we drive towards equity, through these multi-stakeholder collaborations. We started off this session talking about our universal healthcare coverage goals, and we know that many governments, are thinking about how to achieve UHC and how to think about financing schemes that are broadly available and cover essential services, to achieve those goals. We've seen in Kenya, and perhaps Sandra can speak a little bit to that, how through digital platforms and technologies, we're able to actually bring in government financing to increase access, equitable access to high quality care, including that delivered from the private sector. And I think that example, including, I think a number of things that are happening in India with the aspirational districts and the linkage to UHC financing, really does speak that if we all come together to the table with that North Star of how do we provide high quality care to all women and girls, we can do it. And it means making these connection points, whether it's us talking on Zoom or whether it's the digital connectivity that allows the money to flow. And that also allows us to hear back from women and girls about whether they are actually receiving the high quality care that they need. David, there's another question in the chat, for you, which is around, how can we work to ensure, because, we're kind of, this is work that hasn't been done before. Yeah. So we're first movers here.
Yeah.
How is WHO supporting governments to learn, from the best practices that do exist in collaborations with private sector?
Thanks, Marianne. So what we're doing, well, the main thing that we're doing at the moment is running the Country Connector and Private Sector Health platform. So that's a web-based platform which provides a number of different services and resources, both to countries, to governments, but also to the private sector themselves, because we do recognize that this is an area where we need to have discussion and collaboration between government and the private sector. We can't just have the government telling the private sector what to do. That's not going to work. So that's our main platform. So through that platform, we're sharing information, we're sharing tools, we're sharing, we have working groups that are working on specific topics, including maternal and child health in the private sector. And what's really important about the platform is it's a place for people to tell their stories about success. So just coming back to this issue of digital health and women's health, we've got a really nice blog on the website at the moment from an initiative in Pakistan about improving women's health and improving the well-being also of women health workers. And we would like to hear from other success stories like this that we want to highlight so people can learn from these different initiatives. And the last thing I want to say is, I think it's very, very important for us to hear from voices that we don't usually hear from. So when it comes to this topic, we often hear from academics and researchers from the global north, and the points that they make are really important, but we don't hear as much from the lived experiences of health consumers or from researchers from the global south, and we want to do something about that. So this is another opportunity for those voices to be heard. Thanks.
Thank you so much, David. So everyone, you heard it. We want to hear your voices, and there are lots of different platforms for that to happen, and not least in this in this event. And I think Caroline would love to speak to how those voices, what we're hearing, especially as it relates to the role of private sector and multi-stakeholder collaborations, what we can do and what PMNCH may be doing around that. And specifically, Caroline, there's a question around how do we have NGOs better collaborate with private sector?
So through PMNCH, there are a number of multi-stakeholder platforms where you bring together voices of government, civil society, NGOs, private sector. And I think those platforms have been really effective at streamlining messages, advocating for funding and for high quality care and equitable access for women, children, and adolescents. That's one. I think PMNCH also through its design with its 12 constituency groups that represent the full community of those working towards better access to healthcare is also another way to include the right voices in the dialogue, in the decision-making and strategic planning. I think with regards to the private sector constituency and PMNCH, we are doing quite a bit of work with regards to digital technologies. How can we as private sector bring additional innovations and programs and efficiencies through digital technologies? We are looking to highlight best case examples. I think Work for Mothers has been a great partner in that. Some documentation of case studies, best examples that can serve as tools and resources, and also looking to collaborate with a number of global networks and platforms like UHC 2030, the Global Financing Facility, and others that are led by WHO and the UN to make sure that we're all consistently working towards the same end, not duplicating efforts, and really maximizing and capitalizing on the good work that all of us are doing.
Yeah. Thank you so much, Caroline. And I think as I was listening to you, recognizing that this is hard work. And that actually links to another question in the chat around, what are we doing around mental health, as we think about our multi-stakeholder collaborations. And would love to ask the doctors on the chat, how we are already or how we need to be thinking about integrating mental health into the way we think about quality of healthcare delivery and healthcare outcomes. Dr. Malhotra?
A difficult question to answer because my thoughts were actually, Marianne, I wanted to make a point for the previous one first before I address this one. I think over the years, we have understood that the governments need to recognize the presence of private sector. There are many countries where the private sector is not at all, recognized, appreciated for their contributions or, supported. And I think the moment we do that, and we build up a public-private partnership and map the facilities and connect them in a hub and spoke pattern, we will reach much faster in our access and availability, which is concerned. And I also happen to be on the accountability group of PMNCH, and we are trying to do a lot of this work. But since Caroline is here, I think advocacy is also very, very important aspect which has to be looked into and pushed on the government level. Now, as far as mental health is concerned, especially the pandemic, I mean, we have learned so much, but have we really done enough to now appreciate that this is not only for the women, but for everyone, for the healthcare providers also. I mean, we went through so much during the pandemic. People have no clue. I run 2 private hospitals and in the private sector, and with hardly any support, we were like just left in the middle of everything to do whatever we can. There were people who were just leaving the patients at the gate of the hospital, and there's no bed available, there are no doctors, no nurses available. It was, I mean, so everybody's mental health needs care, and that's something which is very, very important. And it's not only the patients. And the moment we will start recognizing this, I think we will become more sensitive, more holistic in our approach in handling people. And this is like a hierarchy. We if somebody is looking after me, I'm looking after you, and you're looking after someone else. And that culture has to be brought in place. You're muted.
Thank you. I'd actually like to link what you just said, to what Sandra said about women wanting respect, and value, valuing. And as you said, if you treat someone right, they're coming out of that experience having a positive experience, and most likely also, to work, with, that perspective. But Dr. Gopal, what are your thoughts on how do we integrate mental health as a standard of care that everyone should be able to receive if they need it?
Mary, this mental health aspect is now getting prominence. For the last 3 years, there is a mental health act was there. As a result of act, many activities have happened right up to a sub-district level. That means district and below district level. Things are happening. The second thing is during this COVID time, we also felt that there is need for teleconsultation, telecounseling, and not the usual telemedicine or the teleconsultation which happens. We require specialized people. That's why during this year, during this financial year, there is a budget announcement to start a national mental health line. Apart from the telehealth, now we are extending this mental health services. Our work is in progress for that. That means you would be having 24/7. It's not the routine kind of teleconsultation. And based on the one-to-one counseling, there would be a specialized counselors for this. It is just taking up in the recent budget, that means February 2022. This announcement has been made. Now work is in progress in streamlining this effort. Otherwise, teleconsultation, things are there. But this is an area where a lot of work is to be done.
Great, thank you. And I think Dr. Malhotra has a follow-up remark.
Yeah, I think one very important aspect is that whatever we learn when we are in the medical school or the college, it takes us a long way. And those habits, once they are formed, they're very difficult to change. So if we actually bring up this education in the medical school itself, whether it's respectful care, whether it is, being sensitive to mental health, whether it is about, interpersonal relationships, everything has to be educated at that level. When we are young, we are more receptive. That's one thing which I think for the future we can actually easily do. Yeah. Another thing which has developed in the last few years in the pandemic was that there were many apps. In fact, I also had one app called iMoms app, where we did sessions every day to support women who were, just locked up in their houses, and they had hundreds and thousands of challenges to meet up, how to go to the hospital, how to get this medicine or, vegetables, food is not there. So technology has really helped us. But what is important is that these apps also have to be providing the right kind of care, because everybody had opened up a helpline. And I don't know whether everyone was giving the right kind of advice. So I think we need to streamline that also.
Yeah. No, thank you. And one of the things I'm getting from this is, we need to go and look at Manyata and see, do we have standards, that include mental health, that are including ensuring providers are seeking and acting on the voices of their clients, because certification and accreditation create norms. And that's kind of what we're in the business in, creating new norms for women, adolescents, and children. There's a great question here that I think speaks to, and perhaps Caroline, you mentioned this, kind of this separation of government and private sector. The question is around the role of community health workers and midwives, who are working in the communities, and how are we thinking about the quality of care that they are providing. So again, Dr. Malhotra links to your point around, the mental health services. How do we know about their quality? And so my question is, are we thinking really holistically about the diverse ways healthcare is delivered, whether it's government, whether it's non-government, which can be private sector, which can be informal, which can be NGO. Caroline and David, how do we pull all of that together in a holistic kind of quality framework?
Do you want to go first, Caroline?
So what I would say is, and there's almost a related question that came through too, which is how do you make sure that you have strategies that can engage that full spectrum of private sector? And as you said, Marianne, it is extremely diverse. And it encompasses everything from an informal provider to a midwife working in a community, to a hospital, to a manufacturer, to for-profit, not-for-profit. So I would say that the very most important step, and it's something that Dr. Malhotra mentioned, which is, one, we need to recognize that there is an entire variety of private sector that makes up a health system, particularly in the mixed health system. I think you have to look at that whole market. I think you have to understand who they're serving, why those clients are choosing to access them, what they're looking for in providers, what's the role they play, are they filling any gaps? And that goes down even to the community level. And I don't have a specific initiative off the top of my head, but I am certain that through some of the organizations that make up the PMNCH community and network of practitioners, that there are efforts underway to also look at the quality of home-based care and the quality of the care delivered by midwives, who are a critical partner at the community level, because many women lack abilities to travel very far distances. They don't have the means. It can't take that much time. So those midwives play a very important role. And so, partners like the partner that you have in JPIGO, and efforts by USAID and FCDO and other donors, I think absolutely are looking at it very holistically from the more formal providers, from the large specialized providers, all the way down to that community-based midwife as well.
They're really great points. I think we'd also really emphasize the importance of taking a health systems approach. So historically, private sector engagement has been very focused on particular health areas, but there are some issues that apply to the whole health system. So this whole question of quality should be the same, no matter whether it's in the public system or in the private system. When it comes to the private system, it should be the same, no matter what the characteristics of the provider. So we do need to do a lot more work to understand what sorts of provision is there, what sorts of provision women and children and other groups need, and what the priorities should be going forward. Because obviously this is a really big agenda, and I think one of the key messages I'd like to get across is we need to prioritize. We can't do everything. It's just not going to be possible. And I just want one last thing I wanted to say was, it's really important to think about how we're going to impose norms and standards on these different kinds of initiatives. So some people are covered by professional bodies. So doctors and nurses tend to have norms and standards which relate to their professional practice and have been trained in those. But there's a lot of different provision out there where that doesn't happen. And community health workers is one example. So we have to think about how they can be given access to training and materials which allow them to produce high quality health services. But also, I don't want to be a doomsayer when it comes to digital health. But at the moment, I think digital health is a bit of a Wild West situation. There's lots of really great things happening, but there are many digital health providers who are not health professionals and who are not subject to any kind of rules. And I think in the future, if we're not very careful, we could see digital health initiatives which are going to be counterproductive towards public health outcomes.
No, thank you, David. Always more work to do. And I'd actually love to pull in Megan around this question of, are there efforts, or how do we think about assessing the quality of care that's provided directly in communities, in homes, or over the internet?
I think that's a great question. And I think that's something that we've struggled with. I think it's important to think about from the women's point of view about how they're experiencing the care and the quality of care that they want and need from it. We've also seen a lot of ceiling effects, where they might have a good experience, but the technical quality might not be there. So I think really using some of the digital tools, Manyata started using them. I think there's a lot out there, but standardizing some of the training and the outreach and the live support that might be needed in some of these situations, and tools like the mental health line that people can pull on when they feel they don't have the expertise needed to handle a situation in the community.
Thank you, Megan. This has been such a rich discussion. I hope it's recorded so those who were not able to join live are able to benefit from all of the panelists' insights, perspectives, and actually concrete recommendations that you all have made. I'd like to move into the last kind of agenda item for this event, which is really around our call to action. And invite each of the panelists to share, what they would like to see and what they would like to ask people to do in order to actually capture this promise of effective multi-stakeholder engagement to improve the lives of women, adolescents, and children. So I will start with you, Caroline.
Thanks, Marianne. I guess I would say one of the things that we've all seen post-COVID-19 is that there were a lot of systems changes, a lot of innovations that made our health systems more resilient. And we got creative and innovative with regards to how we can continue to ensure access to needed services when in-person delivery was a bit challenging. And I would say that the private sector was a key part of that. And I guess my call to action would be, let's look at some of the opportunities that have been surfaced as a result of COVID-19 that included the private sector as a partner, whether as a technology partner, as a service delivery partner, as a financing partner, as a policy partner, an advocacy partner, and let's look for ways to further leverage and maximize those.
Thank you, Caroline. I'd like to go to Dr. Gopal next.
Very simple. If you want to engage with the multi-stakeholders for women's health, we have to first understand and appreciate that women are very much part of our lives. Unless that kind of appreciation comes, things will not start rolling. That we will have to start from there. Then apart from that, every actor, every stakeholder has their own role. We have to see that how we leverage the expertise being brought by different stakeholders, right from civil societies, NGOs, private sector, and the government. Everybody has to work as a team. Then only you can consider that our women are there at the forefront, and all the people, they should work together to deliver the envisaged objectives and the goal. Otherwise, this is not going to happen in silos.
Thank you so much. I would love to bring in Megan next.
I think my call to action is really around training and the access to have that private facility and the private sector can have to these quality programs. And there's really a need and a want that some of these small providers that are providing this care to women in the community, they really need upskilling. They need to stay current, and it's hard to access some of these programs. So a program like Manyata or similar programs can help fill that gap and create a standardized curriculum so that you're not getting something off of YouTube, so that this is endorsed by a professional society that and trust in your community and your nation. And I think that could be a really important step forward.
Although Manyata is on YouTube. So it's about what you get, or being able to discern what you get on YouTube. And your point around training actually reminds me that a couple of weeks ago we had the International Day of the Midwives, and What Woman One campaign around what midwives wanted, and it was very much linked to investment in their professional development and in their training and opportunities for leadership. So thank you for bringing up that point. I'd like to go to Dr. Malhotra now for your call to action.
Marianne, I think we have to identify the need, and we also identified the systems and the processes in place. But what has really been lacking is the implementation and the accountability. Now, once we have, and the larger budgets have to be for implementation and also for accountability, because once accountability comes in place, people will start performing. And that's something which I would like, all the people who are in the driving seat in the countries, the politicians, the bureaucrats, and the health systems to basically engage on. We spend too much time on only identifying and putting the systems and processes, but there's nobody implementing them on ground. There's nobody talking about what has actually happened on ground. And that's something we should be working on.
Thank you so much. David?
I really want to put in a plea for creating an enabling environment for engagement. We've been talking about private sector engagement for like 20 years. And why it's not worked is because in many countries, there isn't an enabling environment. I think one of the speakers said that the private sector often gets ignored, and that can't continue. I think that what really needs to be happening is that we need to get some consensus about recognized health priorities that we should all be working on. And I think consumers' interests and rights should be at the top of the pyramid. We need to focus very much on population health outcomes and public health priorities. We need to build on and create successful agreements and engagement and learn from those over time. It's not just something you can do as a one-off. We're talking about a process, and we really need to create an ecosystem where we can have successful private sector engagement. And last, and I think that this webinar and other initiatives is really important for this, we really need to improve resources and learning about better engagement, because we hear all the time from our member states, they're really keen to engage with the private sector, but they don't know how. Over.
Thank you. So definitely you've given us some work to do. Sandra?
Okay, so I'm going to say that one, women and girls are experts of their own health and well-being. We've said that. And so they must set the standard and norms. So bring in the real experts. Two, on addressing the private sector, I think there are two things that have showed up in this conversation. One, we need to address the perception or misconception about private sector being profit-driven, because that does affect multi-sector engagement and whose priorities matter in this case. But then also in terms of framing, and I'm going to call David out, in terms of how are we framing health as a private sector? Is it a right? Is it a public good, or is it a commodity? Even by use of language, you've been saying, consumers of health. That already tells you the framing is health as a commodity. Can we talk about users of health?
Can I just jump in? I have to jump in here. I'm from WHO. Our mandate and mission is health for all, and that is the purpose of our work. All of our work is focused squarely on ensuring that everybody has the right to have access to health services. We are not interested in commodifying health. I'm sorry, I need to make a very strong statement about that.
And I'm glad you have done, because what we're seeing nationally now, even with the UHC, the model that has been taken is private center. It's private sector oriented. And on the ground, how people are perceiving that is it's for profit. So they're not seeing it as their agenda. And so maybe there's some framing that needs to be corrected, perhaps at our level, because from your level, it's very clear. And I think that is where now we can start working. And then lastly is just emphasizing Dr. Malhotra's point on accountability. We do have a role, not just as civil society, but the private sector has a contributing role in calling for accountability, because truly the health systems in place do not have accountability mechanisms, effective accountability mechanisms that actually ensure that we have the voices informing the standards in terms of the vulnerable the vulnerable groups who are empowered to engage in this discourse about quality of care, and also following up and seeing that actually the duty bearers and decision makers are speaking to their needs and realities. So accountability is also very big. Thank you.
Thank you so much, everyone. And I actually think we have a little microcosm here of what my call to action is, which is really around listening, not just listening to the voices of women and girls, but actually listening to each other, and creating that environment for real collaboration where we can leave our kind of pre-existing notions at the door, and come to the work with that sense of the guiding North Star, of bringing the best of what we can bring to the table in order to improve the lives of women and girls. So thank you, panelists. Thank you, audience. Please listen, listen, and let's work together and collaborate, because this is too important work, to not do and not put our all in. So thank you.